Welcome back, Darrell. Thank you so much for spending more time with us. Since our last session, the world has kept evolving and lots of new things are happening daily. So I really appreciate you spending more time with us because we have a lot of follow-up questions that our audience and community members have sent us. But maybe before we start, can you tell us what is it like for you working at the front line? What are you seeing in the pictures of the COVID pandemic right now?
Sure, Alan. Thanks so much for having me back to chat with you in the group, and thanks for asking. I mean, certainly I was on the consult service last week at my hospital, not specifically doing COVID work, but certainly it gave me a sense of what was going on in the inpatient wards of our downtown hospital. And what we're seeing there and what my colleagues are seeing at other institutions is really clearly that cases are way up right now. There's been a dramatic change in the number of cases that we've seen day after day for the last couple of weeks, really. None of this is really a surprise in a way. The numbers, it was very clear that we were entering a third wave weeks ago, but we can absolutely see that not only in the numbers that are reported each day. We're at like well over about 2,400 cases a day for the last couple of days now, but we see that in the hospital. We see that in the intensive care units. The hospitals across this province are stretched. There's news stories about this as well, that our intensive care units are full. People are unfortunately extremely sick, getting extremely sick from COVID. And there's been a really dramatic shift that myself and other colleagues have noticed in terms of who's getting sick. Concerningly, we're really seeing quite a number of younger people getting very sick. So
like younger as in like teenager kind of younger, or like 50, 60-year-old?
People in their 40s, in the fifth and sixth decades of life, as opposed to, in the first and somewhat in the second waves, we saw people in later decades of life. We're now seeing very severe illness, even in people who are, in their 40s, 30s, 40s, 50s, and this is of great concern. We really need to do a lot more to continue to bring the case numbers back down.
So how do you see the whole road of vaccine play out versus like active treatment kind of research kind of coming together in this fight?
Yeah, it's a good question. I mean, it's been one thing that's been really remarkable in the past year is just how much amazing scientific discovery has gone on in such a short amount of time. And I think it's, something that we can all as a scientific community and as a global society be quite proud of. Treatments in particular have come a long way. We still don't have great treatments, but we have some treatments that seem to offer some benefit to our patients. But that should not be cause for too much optimism because unfortunately, again, the case numbers continue to go up. We still are seeing deaths every day, every week, even here in Canada. And so it tells us that we really must be doing more to prevent infection. Prevention is our way out of this very challenging situation that we're all living through right now. And the fact that we have vaccines available is really an amazing triumph that we should be taking full advantage of as a society.
So I guess one of the key concern with a lot of the vaccines is the emergence of the variant strains, right, of the viruses in different regions of the world. How are that playing out in the current pandemic in Toronto or Ontario?
Yeah, so again, the numbers have been concerning that over the last several weeks, we have seen the proportion of new diagnoses that are caused by these variant strains increase to the point that I think as of several days ago now, we clearly surpassed more than half of infections being caused by these variant strains. So they're no longer unusual, they're now the norm. This is, again, something that was very clear was at risk of happening a few even weeks or months ago. And unfortunately, our inability as a society to shut this down, shut down transmission more successfully has led to this inevitable situation, unfortunately.
Mm-hmm. So how do we, since the trials of a lot of the vaccines that currently are available were done before the emergence of some of the variants, right? So what do we know about the efficacy of the current vaccines about the different variants right now?
Yeah, it's a really good question. It's actually a very complicated question and a hard one to answer as well. So I'll try my best to address it. It's true that the first couple of vaccine trials, so the Pfizer trial, the Moderna vaccine trial, the first two, which were the mRNA vaccines,
Mm-hmm.
those were, I think we can say quite confidently, done really within a context where the variants that we're now seeing were not a big issue. And
Right.
so we can be pretty confident in the efficacy or how well those work against the main strains that we had predominantly been seeing. And that number, it was tremendous, about 95% reduction in COVID with those mRNA vaccines. Subsequently, after that, the other vaccines, the next one that kind of made it onto the scene, the AstraZeneca, and then the Janssen or the Janssen or Johnson & Johnson vaccine, those were done a little bit later, and those vaccine trials were done in different countries around the world. And what is now known is that as those trials were being done, these variants were emerging. They were becoming more common in some, not all, of those settings around the world. And that's also probably part of why the overall estimate for how well those vaccines work at preventing COVID, the same thing that we were talking about with the mRNA vaccines, it looks like overall the numbers are not as impressive. Almost certainly a part of that is because they're not as effective against the some of the variants, in particular the variant that was first identified in South Africa. They have these very complicated names, but B1351. But almost certainly it's because of some reduced efficacy against that particular strain. Now, here in Canada, we're fortunate that that strain has not yet really taken off. Mm-hmm. Most of the variants that we're seeing, the ones that make up that 50 or 60% of new cases in Ontario right now, tend to be the isolate that was first isolated in the United Kingdom, B117 it's called. And it doesn't look like the vaccines are compromised against that strain, fortunately. So it does still look like the vaccines have good effect against that particular variant. But the important thing to recognize in all of this complexity is that the situation keeps changing because the virus keeps mutating, like all viruses. That's not unusual. But what it also tells us is that we have a really urgent and unique opportunity, literally right now, to try to get more ahead of this situation. If we can protect more people now, if we can reduce the total amount of COVID that's circulating in our community, in our country, in the world, globally, through the traditional approaches, such as reducing non-essential activity and masking, hand washing, all of that, but also through this exciting new tool, vaccination, which is extremely effective at preventing many, maybe not all, but many of the variants to a large degree. That's what's going to help us prevent the emergence of even more variants that will be even harder to combat in the future. So it's really a plea to say we have to get more people protected as soon as possible. It's really an urgent situation, and we kind of can see ourselves in a way as in a race against the virus. And so far, the virus it might be winning.
Mm-hmm. Yeah, I think you kind of answered my next question, but I think a lot of people are still with the sentiment that, since the companies are doing more research on, the variants, and, they're also doing about a research on whether there's a third booster dose that might help, the response. Wouldn't it make sense to then wait for better versions of the vaccines to come out? I think from your last rationale, it doesn't sound like that's a good option, but maybe you can address it directly.
Yeah, thanks. I mean, obviously, that's a very thoughtful question, right? I'm glad to hear people really thinking about this and asking, really smart questions. And I think the answer to that is, as you said, really the same, is that I would definitely not recommend waiting for a few reasons. Number one, and the most important one is what we just talked about, is that overall, our goal has to be right now bringing down the total burden of infection. That is the only way that we as a global society are going to be able to prevent the emergence of even more variants and hopefully move us closer and closer towards a world where we can get back to more of our regular activities. The second reason is also really important to emphasize, is that although the vaccines may not work as well against some of these variants, in particular the B1351 that was identified in South Africa for the first time, it's not to say that they don't work at all. They do still seem to have some efficacy, and very importantly, they seem to have very good efficacy still against severe disease, which is the worst possible outcome, getting really sick and having to be admitted to an intensive care unit or even dying from COVID. Those outcomes still were reduced, even in the South African context where these trials were studied in the setting of that variant being quite predominant. And so there definitely is still a lot of benefit that people can get from receiving that vaccine, those vaccines, even if we were to see the emergence of that virus variant here at home soon. So that's the second reason. And then finally, the third reason is that although it's true that we do anticipate that the companies should be able to fairly rapidly adapt their platform to another variant, this variant, that variant, you could make the argument that you could always just keep on waiting, because again, variants will eventually emerge. We know that this is evolution going on in front of our eyes. And so if you're always just waiting for the vaccine to catch up to the next variant, you're never going to get vaccinated. Again, we know that the vaccines do provide some protection, and that the timeline for when you'll have that perfect match between every single variant that's out there and the vaccine that's ready to be delivered, we just don't know. So much better to take a bird in hand, as the expression goes, than to wait around.
So I guess the other question that some of our community members have is that a lot of these Western vaccines were done with non-Asian participants as the majority, right? So how do we know that they are suitable for our Asian bodies, or biologically, are they as effective for Asian people?
Yeah, I think that's a very reasonable question and an important one to speak about. The way I would answer that is to say that, there's been a lot of attempts in discussions around COVID to break things down and analyze them at an ethno-racial, on an ethno-racial basis. But I think it's fair to say that what we've come up with, we've largely come up empty-handed in a lot of those searches. And a lot of the times the things, what research into these issues has shown us is that we're more alike than we are different. And certainly I think that's true in terms of the epidemiology of COVID, in terms of who's getting COVID. We saw more cases in people of African descent, for example, and people started to think, maybe this must be racial. No, it's not. This is explainable by other phenomena around human behavior and social advantage and social disadvantage. And it's not an exact parallel, but once again, if we go hunting and try to look for biological differences between people of different ethno-racial backgrounds in terms of their vaccine response, I really do not expect that we will see much difference. There's really not a precedent for that in the field of vaccinology in terms of knowing that, one vaccine works better in one ethno-racial group than another, or would be better or worse in Asian people than in other people. We just don't see that. And so I think we should have confidence in the fact that these vaccines were tested in many different populations around the world, including Asian people, and showed tremendous efficacy overall and tremendous efficacy against severe disease. If we look at the major trials and count how many actually were Asian as a further argument, it's true that they represented the minority. They represented on average about 4 or 5% of the total study population for each trial. Nevertheless, the trials themselves, remember, are about 30,000 people in one trial, 40,000 people in another. These are massive trials, and so when we talk still about 5% of people, we're still talking about thousands of people of Asian descent who were in these rigorously conducted trials. And now there's emerging global experience in Canada and around the world with these vaccines. And so I think we can fairly confidently still say that there's no reason to think that these vaccines would have differential effects in Asian people compared to people of different backgrounds. And we would definitely encourage vaccination in everybody.
That's great. So you think some of the different levels of efficacy response is more to do with the different variants geographically more than like ethno-racially, right?
Yeah, that really is, I think, what's the leading hypothesis in terms of why we see some of these different, slightly different looking results in different trials, because they're conducted in different settings where the virus epidemiology is different at different times in the last year.
So I guess related to the efficacy question, there's another question about like if we are recommending people who've been previously infected to get vaccinated anyway, because their antibody response might drop after a while. Wouldn't that be the same rationale that raised concern about delaying the second dose of the vaccines to like 4 months or longer? Because if would that increase their vulnerability in the meantime? Do we know how soon the antibody level drops after you have a response?
Okay, so I think the way to think about that question is a very insightful question once again. So thank you for asking that. There's a couple of things I think I would say in response to that. The first thing to say is that we do know that the immune response to the vaccine seems to be more robust than the immune response against COVID after having COVID. Okay, so you get more protection from getting a dose of vaccine, we think, than one does from actually having had COVID. And that likely does translate to the longevity of that protection. Okay. The next thing to say is that in all of the discussions around the delay of the second dose, I think we really need to remember what problem we're trying to solve in proposing a delay in the second dose. The problem that we're trying to solve is not, how do we protect people optimally against getting COVID? The question we're trying to solve is, how do we deal with the fact that we do not have enough vaccine in the world at this moment? It's a matter of production capacity outstripping demand. And in a situation like that, where none of us want to be in that situation, but it is the reality, we just don't have enough resources. What is the best strategy, the smartest strategy, the most equitable strategy, and the best public health strategy in the face of this very undesirable circumstance? And it's if you frame the question like that, I think people can hopefully eventually understand that the goal is to protect as many people as possible so that we can all be protected. Okay, so everyone agrees that if we had unlimited vaccine, of course, we would simply give the vaccine according to the schedule that is recommended. that is not the situation that we are in. And that is not something that any of us, individually, or even as, as a government, as a society, as a country, we can easily solve right now.
Mm-hmm.
And so it's in the face of that circumstance that I think we want to encourage people to just allow the public health system to protect as many people as we can, as quickly as we can, because again, even a single dose does provide a lot of protection, and that second dose will come. And again, there is good reason to suspect that with receiving that booster, subsequently, it will boost levels up and still lead to an improvement in protection beyond what would have been given with the single dose anyways.
So, yeah, I guess it's always like a balance of, both individual and collective benefits in health, right? And we always trying to do the best we can given, what resources we have.
Exactly.
I guess the flip side of that question was that if I got the first dose, but decided not to take the second dose because of unpleasant side effects or whatever reaction, what level of protection can I expect? Is some protection better than none? Even if I had one shot?
The short answer is yes, absolutely, unquestionably. Some protection is better than none. Some of anything that you want is always better than none, I might say. So in terms of numbers, we know that after getting the mRNA vaccines, for example, about 2 weeks after the first dose is when we really start to see the data show us that people clearly have a reduced risk of getting COVID. That risk, in the mRNA trials, the Pfizer trial, the Moderna trial, was reduced by, again, about 95% when people had both doses. But if you look at 2 weeks after the first dose, people already had about 50% reduction in the risk of getting COVID. So yes, that's still a dramatic risk reduction, right? Cut your risk in half, that's definitely worth doing. It does take a couple of weeks after that first dose. It's not instantaneous, but absolutely some protection is better than none.
So I have another set of questions related to kind of vaccine safety. Sorry to have
really
quite a lot of questions, but I guess it really is helpful to address people's concern because I think these are all new things, and I think those are actually thoughtful questions, as you say. So for people who have multiple severe allergies to medication or food, how would we know that they won't be allergic to some of the vaccine components? Because most of those listed are very chemical names, and we don't really actually know what are they in real life things, right?
Yes. So I think, the short answer, I think, is that we shouldn't, I don't want people to get too caught up in trying to figure out, are they or are they not allergic to this ingredient or that ingredient in the vaccine, because the chances are, if you don't somehow already know that you are allergic to this one of the vaccine ingredients, the chances are that you're not. Okay, these severe allergies are extremely rare. They continue to be extremely rare. The estimates keep on changing because our experience keeps on growing, but overall they're very, very small. And people who are allergic to a specific component severely enough to get an anaphylactic reaction typically will know what it is that caused that reaction. And if you know that you got that from peanuts or you got that from shrimp, whatever it may be, those are not ingredients in the vaccine. Now,
but would they be more likely to get an allergic reaction if they have like peanut allergy and has to carry an EpiPen around all the time, for example?
So I don't think we have a perfect understanding of that yet. It is true that among the very, very small number of people who have had severe allergies to the vaccines, higher than expected proportion of those people do also have a severe allergy to something else. Okay, but that's not the same thing as saying that most people who have a severe allergy to whatever necessarily go on to have an allergic reaction to the vaccines. Okay, so I think it's good to be aware if people have a severe allergy to something. It's good to raise that when they go to get their vaccine, because it does mean that they should be observed in the vaccine center for a little bit longer than the average person. The recommendation is to observe those people for 30 minutes, a full half hour, rather than just 15 minutes. And that's because virtually all of the severe reactions are evident within just a half hour. And of course, the vaccine centers are prepared to help folks if they are starting to feel a little bit like they're having an allergic reaction right then. So that's really the main precaution. If you know for some reason that you're allergic to one of those ingredients, then you probably already know it. If you don't have a severe allergy, then it's highly unlikely you're going to have a severe allergy to the vaccine. And if you have a severe allergy to something unrelated, then just raise that when you get the vaccine, and then it'll allow people to observe you a little bit more closely. Most of those people we think are still going to be fine, but there is a small increase in the risk of having an allergic reaction to the vaccine, and that will allow the vaccine center to look after those people very carefully.
So there's also like reports of people who have bleeding disorders or on blood thinners needs to have more caution about taking the vaccine, or people like, for example, like people who have stroke before who are on Plavix or blood thinners. Should they be worried about it? I guess some of that comes from these stories about this sudden death case in the US last year from ITP or something like that.
Yeah, so this is a really interesting topic, and something where I think our understanding of this is continuing to evolve. What we do know is that there are, again, a very small number of people that have had an unusual reaction that now has a special name. It's called VIPIT, or vaccine-induced prothrombotic immune thrombocytopenia. It's a mouthful, VIPIT. Effectively what it is that after receiving the AstraZeneca vaccine, a very, very small number of people have had an unusual type of blood clot happen that might be related to the vaccine. I think the understanding is still evolving. And the mechanism through which this happens isn't quite the same, as far as we understand it so far, as the things that typically cause strokes or blood clots or low platelets. And so it's not quite accurate to say that people who have a prior history of those sorts of things, bleeding disorders or blood clots, it's not quite accurate to say that those people shouldn't receive this vaccine. We don't think it's more common in those settings. So far, most of the cases that have been seen in Europe have occurred in women under the age of 55, and it typically happens within 4 to 20 days after the vaccine is given. It looks like, and so that's the association that's been observed. And again, we're still learning this, and I think many countries, including here in Canada, the National Advisory Committee on Immunization, are taking that information and applying it very cautiously to say that even though we think that overall the benefit from this vaccine to the individual and to society is tremendous, that they're taking the extra caution to say perhaps the provinces, as they're implementing the vaccine program, should be cautious in people in that group, so people under the age of 55.
Mm-hmm. So another question is, there was a precaution, I think, that people are not supposed to get another vaccine within 2 weeks before or 4 weeks after getting the COVID vaccine. Is that still a recommendation, or? That
recommendation, I think, really comes from an abundance of caution and an effort to not kind of overwhelm the immune system in a sense with too much at once, because it's so important to try to generate a very robust immune response in response to this vaccine. We do know that some vaccines, when you administer them in close proximity in terms of timing to another vaccine, that it might blunt the response to one or the other vaccines. You're kind of fighting for your immune system's attention when you do that. Certain combinations we do commonly give in combination, and there's no problem because those have been specifically studied, and that's the way actually we give many of our vaccines. We give them in groups. But because this vaccine is still so new, and it's so important that we get a good immune response, I think the recommendation was to separate it from the timing of the vaccines only to be cautious, not because we have certainty that it's going to change the response.
So I have another list of questions that's related to people's kind of chronic health conditions. Mm-hmm. So some of the concerns were from people who have various kinds of immunosuppression because of cancer, of HIV, who have very low CD4, or on certain immunosuppressive treatments like dialysis or other things. They're concerned about like whether they should delay till their health is more stabilized or get better, or whether they would get a more severe adverse reaction from the vaccine when they're not so well. So what would be your take or recommendation about that?
Yeah, so I think it's a very understandable question. So let me answer the second part first, which is to say, would people get a more severe reaction or a worse reaction from a safety or tolerability perspective from the vaccine because of having an immunocompromising condition? And the answer to that is no. We really don't expect that to happen. There's no reason for that to happen. If anything, they might have less side effects, because we know that most of the side effects that people get from the vaccine are just related to the vaccine successfully triggering their immune response to work. Should they delay their vaccine dose, or is there some threshold of immunosuppression below which we would suggest that people hold off on getting their vaccine? Again, the answer from me would be no. And the reason for that is a few things. The first and an important priority, or the first point to make, is that really the priority here has to be, as we were saying before, getting as many people protected to some degree as quickly as possible. And that is the only way that we're going to bring down everybody's risk, including the person who's immunosuppressed themselves, by just bringing down the amount of virus that's circulating. And one dose of the vaccine is better than no doses. And one dose, even if it leads to a slightly blunted response or not as impressive a response as we might expect if the person was in their usual state of health, or compared to someone who doesn't have that same condition, that's still going to be better than getting no protection. And finally, the point is that another point that I would make is that the reality is that some immunocompromising conditions, many of them, in fact, unfortunately are quite challenging or difficult, if not impossible, to change. Some of them there may not be a clear date in the future when that person is confident that their immune system will be, at the same level as we would like it to be. And so once again, for that reason, I think my recommendation would be get the vaccine as soon as you're eligible, and don't delay.
Mm-hmm. So if you're like taking antibiotic for bronchitis or something, you could wait till you finish. But if you're on a long-term treatment that is not likely to finish within a reasonable time, you would not wait to get the vaccine, right?
Sure, yeah. If someone has a really acute illness and it's really expected to get better in a matter of days, sure, that's reasonable to wait just so that you feel a little bit better. And we also think that's a good idea so that there's no risk of kind of confusing something related to their illness as being caused by the vaccine. So that makes sense. But in general, if we're worried about, someone's worried about their getting the vaccine because they have a chronic medical condition that's unlikely to change anytime soon, the recommendation really is get the vaccine when it's made available to you, because you will still get some protection, and that protection is really valuable.
So what about kind of medium-term kind of treatment like Hep C or TB that is a few months kind of treatment, would you wait till you finish those, or would you do it together?
I mean, I think some of this is going to be, of course, well, all of this is a personal choice, right? We're not forcing anybody to get the vaccine. If I was speaking to my own patients, my own family members, myself, I would say get the vaccine despite receiving that other treatment. Perhaps it's reasonable to wait until you know that you're tolerating that other treatment. You know, maybe don't get vaccinated on the first day of a brand new treatment, just so your body can get a little bit used to it. But, you know, most of the medications that we use these days are things that our bodies get used to in a matter of days. And so I think if someone has started a treatment and is now comfortable using it, it's been a couple of weeks or something like that, and they're not having any major issues, that's a great time to go ahead and get this vaccine, because again, it's going to offer some protection. And again, people who have other underlying medical conditions might be at higher risk of having a worse outcome if they do get COVID. So it would be wise to get that vaccine as soon as it's available.
Mm-hmm. So it's good to just wait until you know that your body is tolerating whatever treatment you're on, and so you actually won't confuse it with side effects from the vaccine, right? But not waiting too long, because your risk of getting sick from COVID is actually much more serious than not taking the chance of getting a little side effects, right?
That's right. I think it's really important to remember, in Canada, we've seen 15,000 deaths and climbing. And as we were saying earlier, people even who are younger than in the first wave are in our ICUs fighting. Mm-hmm. And so we really want to prevent those terrible outcomes.
Yeah.
So we have vaccines.
Mm-hmm. Finally, I guess the big question these days is the fact that the government of Canada has put on hold the AstraZeneca vaccine for the 55-year-old or younger population. Mm-hmm. So does that give people really mixed messages about safety and concern about the vaccine? And how should we interpret that?
I think that the way that I look at it is actually exactly the opposite of that. I don't think that it's I don't think that it should make people concerned about the safety of the whole enterprise of delivering vaccines. I think what that tells us is that our public health authorities are watching the data in real time, are being proactive when there's reason to be concerned about something, being cautious rather than being cavalier, and being evidence-based in every decision that they make, right? So I think, to me, this should be encouraging to those who are a little bit apprehensive, to see that the government is going to respond to data as it emerges and try to balance the safety concerns that people might have until we know more. It's really important to emphasize again that when you go about doing this really weird thing that we're doing right now, which is literally vaccinating millions of people with vaccines in a very short amount of time all over the world, that things are going to happen that might have happened otherwise, that will, by coincidence, in some people happen shortly after they get a vaccine dose. And when you do this, it's impossible to know for certain what is and what isn't caused by the vaccine. So governments, in this case, the National Advisory Committee on Immunization, or NACI, when they see something happen like that, they have to ask themselves the question, is this a coincidence, or is this caused by the vaccine directly? Again, it's impossible to know for sure, but they're taking a very cautious approach now that we have a bit more information. And I think people should actually see some encouragement in that. It's also maybe important to just remember that COVID is a really strange situation, because we're learning in real time. Again, this whole pandemic is only 1 year old. All of the science, everything that we know about it, is evolving in real time, and it can be hard to appreciate this, but it really is true that means that the science evolves. We unfortunately, there's no point at which we can be absolutely certain that we have perfect knowledge about everything. What all we can do is act intelligently, ethically, and wisely with the best knowledge that we have at any given moment. And that means that there will continue to be changes. But the best recommendations right now are still that we do need to bring this virus level down. We do have vaccines that in the vast majority of the population are still going to be very safe and effective. And governments will step in and adjust the plans accordingly as new data comes out.
And are we seeing like similar adverse events in Canada or about any of the vaccines that, like people hear about these horror stories, and then kind of lose sight of some of the big picture, right? Because in real life, we are rolling out, as you say, like, millions of people are getting it. Are we keeping track of the responses locally?
Absolutely. Yeah, thank you for asking that really important question, Alan. We have not seen cases, to my knowledge, that have been reported of anything like that VIPIT that we were talking about earlier, that vaccine-induced phenomenon that was observed in some people in Europe. And that's despite, I'm looking at the website right now, 5.3 million doses of COVID-19 vaccines being administered in Canada so far, 672,000 people being fully vaccinated. So the numbers are not where we want them to be, but they're still huge in the grand scheme of things in terms of how much data we typically have for most decisions that we make in medicine. We have a huge number of people who have successfully received doses of this vaccine without any signal that there's a safety concern beyond a bit of soreness in the arm or feeling a little bit under the weather, which is to be expected. So I think, again, we should be confident that these are extremely rare things that we're talking about here.
And you've been vaccinated, right?
I signed up for my first dose as soon as I got it. My second dose was delayed. It was originally going to have already been done, but I got the notification just like everybody else that it was going to be 16 weeks, and I totally understand why, and I think that was the right decision. And I'm going to wait my turn for my next dose when it's available to me.
Great. Thank you so much, Darrell, for spending time with us. I hope that we can all join forces and work together to win this fight together.
Absolutely. Me too. Thank you so much, Alan. And thanks for the great work that your team is doing.
Thank you. Take care.
Thanks. Bye-bye.
Bye.